everybody. Croeso, welcome to our board meeting. This is the first time we've had a board meeting in such a format where some of our board members are at home and some of us are socially distancing here at headquarters. So please bear with us that we get it right as we go through. We've got a huge agenda, but thank you. Many of the independent members have given us their questions in advance, so that should hopefully make the meeting shorter and also clearer. And I'd be grateful if everyone could restrict themselves to just adding to what's in the papers and answering those questions rather than talking us through the papers. It's much more difficult to have a meeting when it's online, and it's better if we keep it short and succinct. So thank you, everybody. So I'm going to go straight to the agenda. Any apologies for absence?
Yes, Chair, we've got Karen Miles, Director of Planning, Performance and Commissioner.
Thank you. Any declarations of interest? Okay, thank you. If we go to the minutes of our meeting held on the 16th of April 2020, are there any inaccuracies in those minutes? Okay, is the board happy to accept them as a true and accurate record? Thank you. We then go to the table of actions. Firstly, from our meeting on the 26th of March 2020, they all seem to be completed. Are there any questions on that table of actions?
Yeah, one point of accuracy, Chair.
Yes, who's speaking? Phil.
Bill, one just brief point of accuracy on PM 2035. It says confirmation that 14 of 32 TAVI patients are from Hywel Dda. Actually, I've had confirmation from the medical director in Swansea Bay that it's 17 out of 32, just for accuracy.
Thank you, Phil, and that's really important. And if I could now go on to the table of actions from the Health Board meeting held on the 16th of April. Are there any matters of accuracy or any questions on that table of actions? No. Okay, thanks everybody. The next item on the agenda is my report. As we all know, it's been an extremely difficult and challenging 2.5 months. Many staff are very tired, and many staff across the whole of the Health Board have made personal sacrifices. I'm sure the board will agree that the collective efforts have been phenomenal. And I'm sure the preparation which is taking place in this Health Board and the dedication and the commitment has saved lives. So on behalf of the board, I'd like to thank all our staff, our Chief Executive who's led us during this period, all the executive, for everything they've done and they continue to do. As we said at the beginning, this isn't a sprint, it's a marathon, although we've been running it at a sprint, and we will continue to do all we can to keep people safe and to care for people. And I'd also like to thank all our partners and our communities. We've all truly worked together to care for people and keep them well, and it's wonderful to see how people have been able to remain at home and in isolation and being cared for by the communities. I'd just like to draw your attention to a few items in my report. Firstly, how the Health Board immediately set up mechanisms to support staff welfare during the pandemic. This was fundamental. There's been a huge human cost for everyone with the stress and the anxiety and the experiences that people have been going through. And as a Health Board, we are committed to taking this forward in the future. And I'd also like to take the opportunity to thank the public for their incredible generosity. Many gifts have been forthcoming to support our staff, such as food, personal protection equipment. And we've also received £105,000 for staff welfare from NHS charities and £85,000 which has been donated here in Hywel Dda. And a special thank you to Mr. Ridwin Evans, who, inspired by Colonel Tom Moore, walked around his home 91 times to mark his 91st birthday on the 18th of April, and he raised an incredible £43,000 for our health charity. So we're going to hear more details later in the board on how we will use the monies to continue to support our staff. And we will have, this will come back to the board in our next meeting. Another item I'd like to draw attention to, which I'm really proud about, we've achieved the Care Confidence Level 1 accreditation, which has acknowledged the support that we've given to our staff who are unpaid carers. And I think if we go back a few months, we did have a very moving patient story from a member of staff. And a lot of work has been done within our for our community and within our health boards to support unpaid carers. And I'd also like to pay a personal tribute to everyone who contributed to the New Look Ward 10 at Withybush, which has now reopened. And finally, I'd like to congratulate Judith Hardesty, our Vice Chair, who has been reappointed as Vice Chair by the Minister for Health, and also Delyth Rainsford, who's also been reappointed by the Health Minister, and particularly at this moment, at this time of change and challenge, it's really important that we have dedicated, valued and experienced board members for the continuity during this period. And I also have in my board paper a chair's action, which I'd like to ask the board, are they happy to ratify? It's in relation to our care homes. The board's happy to ratify that? Yes, thank you. And are there any questions on my chair's report? Delyth.
Sorry, I unmuted myself. Can I just ask, Maria, I note in your report you've met with frontline staff. Are there particular messages that they're giving us as a board? What's concerning them?
The messages that I have heard, and they vary. Some of the frontline staff on the COVID wards are saying it's been relentless and how the hardest thing for them is families not
now joining.
Because they find that heartbreaking. It's different from usual practice, and I know they're doing everything that they can to care for the patients. I've heard from some staff that they're too tired to apply funds for charitable support for their welfare, and you know, things like they don't want vouchers because they don't want to go into shops, but they would prefer some gifts. I've also heard that the support in our care homes, both through expanding our emotional and welfare support to our care homes and working together, has been phenomenal. Everybody has been overwhelmed by the kindness from the public, and some of the gifts that have been received, you know, like fresh water. I went into one of the hospitals and there was a whole area just full of water bottles from one of our suppliers locally. So it's been an overwhelming time, and you know, as you can see in my report, I've given quite a number of Chairs Awards out as well. The people who've really gone over and above, people who are not able to live with their own families because they're protecting them, and working so many long hours. I think there's a sense of pride as well in what they've achieved and a great service. And I think one of the messages that Steve has been given, and we've all been given, is, you know, people need to take their leave as well and rest and get their energies back, because this is a long journey. But I've been overwhelmed and humbled, seriously humbled by the work that's happening, and to see what's happening in primary and community care. And we'll see that in the report that's coming in the Q1 report. We've actually delivered our strategy in the community, parts of it, in weeks, which may have taken us years, and it's enabling people to stay at home and keep well. But that's with our communities. It's a true health service, not a sickness service.
Thank you. Thanks.
Judith?
Yes, thank you. I mean, I'd obviously like to echo everything you've said. I'd just, if I may, just also thank people who've kindly donated items to our mental health areas. Obviously, they're areas that haven't been caring for patients with COVID, but they are areas where there are challenges for the staff. And there's been some wonderful donations of things for the garden, things to use on the ward, which I know the staff have really appreciated for those to come in. So I just wanted to add that to what you've already said. Thanks.
Thank you, Julia. Any other comments or questions?
Chair,
Yes,
may I?
please come in.
Okay. I just wanted to agree with the comments you've expressed at the bottom of page 2 about the magnificent support from the community. We've seen the creation of numerous community and social media support groups in all 3 counties, with key roles played by local authorities and CVCs. And I'm the member of one such group in Pembrokeshire. And in Pembrokeshire, we've got a community hub which has seen 4,000 calls, 600 people volunteer, and 85 community groups being established. So in dealing with this terrible pandemic, it really, in every sense, has been a whole society effort.
Thanks, Simon. I totally agree. And our local authority partners, we've all been together focusing on our population and our patients, and I totally agree. And I hope that those amazing community groups which have risen to care for everyone continue post-pandemic, because it really is a social model of health that we're seeing in action because of the response to this awful pandemic. So I totally agree with you. Thank you. So thank you, everybody. If I go on to the next paper, which is maintaining good governance during COVID, Joe, do you have anything to add to this paper?
No, Chair, it's just an update on the arrangements that we've made at the last board meeting. So I think somebody's not on mute and it's just giving an echo in the room. Sorry. So just to say it's an update on the last board paper from the position we were. The thing to call out is obviously we're still not operating fully in accordance with our standing orders in not being able to. Why we've obviously we're putting the draft minutes on the website within 7 days of the meeting, and we're also going to put this recording on the web today, which will hopefully help with making sure we're more compliant with standing orders. But we are working to get back into live streaming our boards as soon as we possibly can.
Thank you. And as we mentioned when we stayed at last board, that is really because all our IT teams have been working out in the hospital, helping people to remain at home and work from home, and they've done an excellent job. Thank you. Steve, I wonder if you'd like to speak to the establishment of the Transformation Steering Group.
Yeah, well, I was going to cover it under my main update on 2.3. Shall I do it now?
No, 2.3 is fine. It'll be all together then. That's wonderful. Thank you. So the board's happy to accept the recommendation. Thank you. If we now move on to the Chief Executive's report.
Yeah, thank you, Chair. I'm just going to go straight to the recommendation. This is a shorter report than normal because actually my main update will be under agenda item 2.3 on the COVID update. So I'm just asking for an endorsement of the Register of Ceilings, to note the consultation documents, and to note and approve the Major Trauma Memorandum of Understanding. I'm happy to take any questions.
Any questions? Board's happy to approve. Thank you. Next is the report of the Audit and Risk Assurance Committee. Paul, have you anything to add to your paper?
Nothing to add to the paper, only to say that we had a audit committee meeting yesterday where we managed to clear some of the internal audit reports which have sort of hung over from the end of last year. In the meeting I expressed my thanks to the executive team for turning around the management responses to those internal audit reports to enable us to deal with them yesterday. It certainly helped to speed things up.
Thank you, Paul. And the board notes your matters of concern, and that will be continuing to be considered by the audit committee. Thank you. Next item on the agenda is the Improving Patient Experience report. Mandy?
Yes, thank you, Chair. I'd like to start really by thanking Louise and the team, because the report itself, which is attached to this particular paper, is extremely detailed. It does contain a patient story, and clearly, even though it's quite a brief story, there's already been learning demonstrated as a consequence, mostly around the links in with established national learning referral schemes. So that's been a real positive, plus the ability for the team now to capture patient stories in a much broader way, I think will help us and enrich the learning that we get from storytelling. The other thing is I'd like to call out the fact that the team have worked relentlessly, the patient experience and health team have worked relentlessly, as you'll see in the report, to support families and patients at this very difficult time. So things like the stop and drop, the work that they've been doing on digital to enable families to communicate through iPads, the work that they've done around the email communication so that the personal touch hasn't been lost. So I think that's really, really commendable. And apart from that, I didn't intend saying anything more other than just to reiterate that whilst we're celebrating a 92% satisfaction level, it's just to say that that 8% where we haven't had such positive results given to us doesn't go unnoticed, and that's where we target a lot of work, but also focusing on how do we expand and develop further all the activity that we know has led us to have this 92% success in terms of satisfaction. So I'm happy to take questions.
Thanks, Mandy.
Judith and
Okay, Anna, then Judith, then Mike, please.
Thank you, Chair. I just wanted to provide the board with assurance in relation to item 15, learning from events, on the full report here, that it reflects once again a recurring theme around communication being an issue that patients regularly raise with us, and that we discussed this at the last QSIAC meeting and have agreed that we will take a very thorough look at this trend and this theme in QSIAC's work programme over the next few months. So I can provide board with assurance of that, and we've agreed that through QSIAC.
Thanks, Anna. Judith?
Thank you. My question relates to the patient story, which I did watch. It's very good to see it. I think my comment would be that whilst it does evidence there's some action being taken, not all of the points that were raised in that story have actually been addressed. And I think it may be helpful going forward to have an easy sort of that to say this was raised and this is what we've done. So I haven't particularly, I thought the issue about the GP surgery information in relation to that story. But I wonder if we could look at how that could be probably addressed going forward as we receive future reports. Thank you.
Absolutely, I'll take that on board. Thank you, Judith.
Thanks, Judith. Mike?
Thank you, Chair. Mandy, thank you for the report. There's reference at the top of page 14 to a response that was due with the Ombudsman by the 11th of March. Can you just confirm, please, that that response has now been submitted?
Unfortunately, I can't confirm that the response has been submitted. I do know which service it relates to, and it actually relates to a very specific issue around the establishment of a service users group, which obviously, given the current circumstances, has been delayed. The team are very much in contact with the Ombudsman's office so that he is aware of the reason for the delay, and there are ongoing discussions with Andrew Carruthers and the team about how we actually can make that happen in a timely way. But certainly that's the latest update that I've had.
Okay, thank you.
Chair, could I ask one question, Mandy? Thank you for the report, and I can, from personal experience, say thank you as well for the drop system that Howells have been utilising. I've got one question about children, young people, actually. Whilst I welcome the pilot scheme for the rights of children, young people, have we managed to collate any views from any of our children, young people involved within our services during this pandemic? And did we feed into the Children's Commissioner's survey that was live a week or so ago?
If I start with the survey, I believe we did, Stella. That's the feedback that I had from the service. And that was I believe that was positively received by the team having that opportunity. In terms of the feedback from children and young people, the piece of work that Louise and the team will be doing now is making sure that we capture feedback from people, regardless of their age and which service they've been engaged in, as their experience of services during COVID, because we feel that's really important. It will also help inform the work that we're doing on a much broader basis that Steve's group is leading, Chief Exec's group is leading, around transforming our services, because the experiences of patients will help shape and influence that going forward. So the children and young people, absolutely, but we're also looking at whether we can broaden that out to capture primary care, mental health, acute services as well.
Sarah wants to come in on the same point.
Yeah, so Mandy's absolutely right, but just a bit of further detail on the Police and Crime Commissioners questionnaire. As you'll recall, we launched a joint project, so we part-funded that. So that is our questionnaire as well as just the Commissioners. So we'll have all of that richness coming back. And we're also in conversations with the Children's Commissioner, with Sally Holland, about what we will do across Wales and how we play our part in collecting the impact of COVID on young people and what public services responses should be.
Thank you. Thanks.
Chair?
Can I bring in Sam Denton from the Community Health Council, please?
As you all know, with the CHC being the statutory voice of patients, I think that voice has been overwhelmingly supportive and grateful of the efforts of NHS staff. And I think it'd be wrong not to note that at the outset before I go on. So just really important to emphasise that. The CHCs across Wales have been running a survey around asking the public what it's like to access NHS care during this period. And the public has been pretty active in getting back to us. Firstly, I want to thank Health Board colleagues for being so helpful when we've taken the issues that different inquiries have brought. That response has been really swift, and I can only thank Health Board staff for that. I think the outcome of some of those inquiries hasn't always been as positive as we'd like, not because anyone's doing anything wrong, but because NHS services remain really quite narrowed, as people might expect during this period. But that leads me on to my next point, which is really to support what Anna said. It's going to be absolutely crucial, and it's going to be a huge task amongst many other huge tasks that you've been undertaking of late. It's the importance of having really detailed, up-to-date information across the myriad of services that will start to be working, not just because they're working again, but because they will be specifically different in the way that people will need to access them and use them. And it's going to be really crucial for people to A, understand what is open, but B, how they use that service. So we're really happy to help with that, but we see that as really, really important as this next phase, as services begin to grow back again.
Thank you, Simon, and I think we're all in agreement with that. We look forward to working with the CHC. You've got, access and as responsible for the patient voice in our society. So thank you. Simon, you have a question?
Yes, please, Chair. The total number of compliments, we've had 58 formal compliments, and I think that must be the tip of the iceberg. What can we do to obtain the data from all service settings so we get a really good, accurate and complete picture, especially since staff are currently under unprecedented pressure, and we need to remember how recognising and praising their great care will increase their confidence and, make them aware of how much their efforts are appreciated.
So if I can just respond to that, Simon, because the challenge we've got, as you quite rightly say, is making sure that we do not place an additional burden on frontline staff to actually capture data. What I would say, you're quite right, that is a very low number, but that's the number that we get sent either through letters of compliment through to the Chief Executive or the Chair's office, directly to myself or the Medical Director, or where staff actually share a letter that's gone directly to them. What we don't get are the hundreds of thank you cards that go directly to individual clinical areas. And having worked on this type of activity previously, it is an extremely difficult one to crack, if I'm brutally honest. So we will continue to look at how we can capture it. Certainly the work that we do, the survey work, allows us to capture positive compliments as well. The fundamentals of care, which you will see in the papers later, also provides an opportunity for us to capture any positivity that comes out about people's experiences. So I haven't got a single answer, but it's something that we will continue to try to improve.
Thank you, Mandy. And I think part of our patient walk-arounds as well, we can see all those cards. Unfortunately, they're not happening at the moment, but they exist. I'd like to pick up a few things outside, but be in the listening and learning group, and that's about the Relay UK and the hard of hearing and deaf community, GP complaints, how they're actually processed. And I'd like to know more about the family liaison service. It's wonderful to see that that's going to be in place to enhance communication, and I'm sure that will be considered in Quasiac. But could you pass our thanks to the team? They've been almost like the connector between the service and the public during this pandemic, and massive thanks for everything they've done, and the soft things that they've done make such a difference. You know, those little things of kindness and care and a listening ear. So thank you.
Thank you.
So board happy to note receive the report, and thank you for taking comms through Quasiac, and also Mandy will look at the, you said we did pass at the report and feed things back. Thank you. Then if we go on to the health and care standards, fundamentals of care, audit.
So again, I won't go into huge detail here. I think it's probably, I need to say at the outset again, this is thanks to Helen Humphreys predominantly, because the amount of work that she does to pull together what you will see is an extremely detailed report is nothing short of a miracle, given the work that she's doing at the same time on the nurse staffing and all of the COVID staffing activity as well. This has been considered through senior nurse midwifery team meeting, and unfortunately trying to get it here meant that I didn't then get it into Quasiac, but obviously we'll do that retrospectively, because again there are some issues that I suppose that if I was honest, I'm a little bit frustrated about, and that was predominantly the fact that we still haven't seen the level of improvement that I would have hoped from the work that we've been doing around pressure damage. So leading with pressure damage information leaflet, we need to make sure that we're doing more with that. We introduced our scrutiny meetings. That hasn't resulted in the level of improvement that I would have liked. So we're revisiting whether that is actually, what more can we do to make that a stronger position so that we ensure that patients have the information that they need to help them avoid pressure damage in the first instance. The other issue around rest and sleep, that came up last year. We have done some work on it. Unfortunately, our clinical environments are noisy, and given the nature of some of our clinical environments, given the equipment that we use with the beeps and monitors that occur 24/7, we will never eradicate all noise, but everything that we can do, we will continue to do, and we'll look again at what more we can to try and make the environments as calm and as quiet as they possibly can be by night. Obviously, when we look ahead to new builds and look at more single room activity or provision, that will inevitably help us, because I'm sure as anybody who has been in hospital recently will attest, sleeping in a 4 or 6 bedded bay when perhaps you're used to sleeping in a single room or with just one other person in the room is quite a difference in itself. So that is something that remains a frustration for me. The documentation element, which always has an area for improvement, is something that we are hopeful will actually improve in terms of the activity and more immediate learning once we have the electronic nurse staffing record rolled out. So work is going on with NWIS, our National Informatics Service, to support that piece of work. So more than that, I don't want to say, but I'm happy to take questions.
Thanks, Mandy. Maynard.
Just turn my mic on. Mandy, in your main paper on page 2, patient experience, it just picks pages 6 to 11 of the report. The last sentence of the second paragraph says that where there is comparable data, 4 questions have seen an increased percentage compliance compared to last year. 12 have seen a decrease in percentage compliance. Does that mean there's an overall trend downwards, or is it just marginal changes that would fluctuate year on year?
Thank you for asking that, Maynard, because it's reminded me to also tell you that there was an error in the paper, that you would have spotted it, I'm sure, in terms of the patient experience numbers of patients and carers. It's down as 1548. It's actually 1508. So just to clear that up, I apologise for that. With the level of detail that was in the report, we overlooked that one, so apologies. In terms of the decrease, we have got 12 areas. They are negligible. We still have 11 out of those 12 areas remaining green, i.e. they've met the minimum, they've met the standard that are required. We've got 1 area that is in amber, and that's where we'll obviously continue to focus some work. They are very small percentage drops, which I would argue aren't significantly significant. However, if you are that one patient, it is significant to you. So it goes back to the fact that we are not complacent. So they're not, it's not huge variation. Looking at, and it is linked to the number of patients that we've got that have responded. But if I can just give you an example, a 1.38% drop in one of the standards relates to 2 patients feeding back. And when you think that we've had over 1,500 patients feeding back, it's that sort of scale of drop that we're looking at. So they are very small percentages, but nevertheless, they're something that we do take very seriously.
Thank you, Mandy.
Anna, did you want to come in respect of Quasiac and this report?
Thanks, Chair. I think only to reinforce what Mandy has already said, which is that we'd like to take a close look at it at Quasiac and be able to give it some detailed attention, more so than we're able to in board, and we will do that as quickly as possible.
Thanks, Anna. Devin?
Hi, thank you. Can I just note that there has been a percentage rise in patients being able to speak the language of their choice, i.e. Welsh, which I really welcome, which will make patient stay much better for them. Thank you.
Any other questions? Okay, the board's happy. Well, the board's happy to accept the recommendation, or do you wish to change it to note the report subject to the detailed scrutiny by Quasiac? Yeah, detail. Fine, that's grand. Thank you. So the next item on the agenda is COVID-19 report, and that's over to you, Steve.
Yeah, thank you, Chair. And apologies for the huge amount of detail here, but I think it does show the amount of work that's been going on across the organisation. I think I won't go through the detail of the report. Hopefully it's a helpful update. But given that things are moving quite quickly, there may be some further updates, even since we wrote the report, that members of the team who are leading on various areas may wish to give the board, and I'll mention a bit of that in a moment. I guess the first thing to say is our response to this pandemic continues to evolve, and to pick up what the Chair said at the beginning around the rate at which our staff are working, the pressure they're under. Actually, we're seeing that also in other teams. So the hospitals remain very busy, as I'll mention in a moment, but also the work that's going on with our testing teams out with our care homes has just been phenomenal. And it's always there is always so much going on. It's difficult to keep a tab on everything that people are doing, but Jill was able to describe to us yesterday a team that has been massively dedicated to supporting our care homes through this pandemic, who are working 7 days a week. They're doing 8 care homes a day from next week on mass testing. They've pretty much been relentless for weeks now, and it's very easy to miss that. And actually, we want to do a bit of comms around some of that. To mention them is probably to then not to fail to mention others, but there is a huge amount of work also going on in the wider system. But it is very much a whole health board team effort, I think, as we move through this. So it's only been a month since we last met, but in writing this report, it did sort of demonstrate to me that so much has happened even in the space of that month. So this paper and attachment is intended to give you a sort of summary of where we are. And I say I do apologise for all the attachments. I hope nobody felt the need to read them all in detail. It was more to give you a sense of the scale of what was going on. In terms of where we are today, the number of COVID positive and suspected patients in our hospital thankfully continue to fall. At the time of writing the paper, we dropped from circa 90 or just over down to around 70. As of this week, we are around the sort of 40 mark, which again is really positive to see both that the peak wasn't as high and we continue to see reductions now. And I would just, as well as paying testament to our staff, pay testament to the public who have shown real solidarity with the NHS locally. We've seen that particularly at West Wales, I think, which is really positive. And I think we all want to thank the public for that. We have also started to see over the last month increases in unscheduled care for non-COVID patients. So whilst the hospitals may seem relatively quiet, actually they are very busy given the way in which our services now have to be organised to manage COVID and non-COVID areas. And I think it is a sign of some positivity that people are feeling that they can come to the NHS for non-COVID reasons now, because we are there to help. And that message doesn't need to be out there with the public, but if they need the NHS, we are there for them. The report also sets out, since the last meeting, the significant change to our planning requirements, and I think this picks up the comments from Sam at the CHC around now trying to focus on a wider, more longer-term response to the pandemic, and also to, as part of that, to establish a public health cell to help with the local establishment of the test, trace and protect process. Our tactical group and our bronze groups have been working on that revised planning requirement now for about a month, and actually what has come forward, and you'll see it, and I would encourage you to read this if you can. The Q1 detailed plan was the result of all of that very careful thinking. That was clinically led. These are really difficult, finely balanced judgments about the care and consideration with which we start to reopen services to protect everybody. So they are cautious, and I think that is the right thing to do. But they do now start to balance the need of a wider group of our patients and public. And I see this very much as a first step, and now we're in the process of thinking about Q2 and indeed Q3. But we need to go step by step. And I would just pay testament to the work that Andrew and Jill have done as tactical chairs on this to pull all this together. And it was held up by Welsh Government as being a really comprehensive, probably the most comprehensive plan across Wales, which again I think is a testament to the work that they've done and their bronze groups. The update also covers various areas which I won't go into in detail, but I'll just mention the executive lead in case there isn't any questions around the very current position on these. But in terms of protecting our staff, and particularly the risks for our BAME staff, Lisa is leading that piece of work. On PPE, Mandy continues to lead on that. On patient safety as well, Mandy is the lead. For testing and more generally our TTP approach, Ros and Alison working very closely on that. And for communications and the command centre, Sarah is leading on that. So if there are a need for updates, we'll have those now. Again, it's the scale and the speed with which we're working. Just a couple of last things before I shut up. The first is to apologise to the board about the problem that we experienced since the last meeting around our death reporting. It was discovered just after the last board meeting as a result of reviewing our systems and processes. I can assure you that the correction went in. We were missing on average about 1 death a day for about a month, so there was a correction of circa 31 deaths. It is really important we get this data right, because whilst it isn't the whole truth about what's going on with COVID, it is important sensitive and surveillance data for Public Health Wales. So apologies that happened. It has been corrected. We now have a stronger process in place, and that's been running for the last month to triangulate the individual clinical reports with our information systems that we hold to ensure that we don't miss any reporting. And as the chair mentioned in a preamble, sorry, I was slightly not ready for it then, but I'm ready for it now. The report also sets out the replacing the Recovery, Learning and Innovation Group with a Transformation Steering Group. That's partly in recognition of the fact that much of the recovery work is now going on through the bronze and tactical groups because of the revision in the planning requirements agreed by the gold group, but also a sense that there's a much wider net to be cast here around the kind of transformational changes that we're seeing, and an opportunity for us to make this part of the way in which we work in the long term, so not just as a response to the COVID pandemic. So an initial exploratory meeting has been established on the 8th of June. Really the job of that initial group is to look at the role, the membership and the operation of the group, and to identify any early themes that we can then bring back to board at its future meeting. But I expect this to evolve. We need to get the governance of it completely nailed down, but it feels to me it's the right thing to do is to start and then see where we go with it. So we'll bring back further reports on a more formal terms of reference to the next meeting, having had the establishment meeting going. So I'm happy to take any questions, as are other members of the team on the individual areas.
Thank you, Stephen. If I could just add to the last point about the transformation steering group. Della, you asked me what frontline staff were saying, and many were saying they don't want to go back. In the Q1 report, there's some really innovative examples of fantastic work, and staff are saying they don't want to go back. It's been a period where they can make decisions quickly together with others to improve patient care. And so the innovation steering group and this whole work hopefully will capture that for the new future, the new normal that we're going forward to and not going backward. Now, quite a number of people, as one would expect, wishes to ask questions. So on the transformation group, Paul, I think you want to come in, then Judith and then Mansell.
Yes, thanks, Chair. Could you clarify, Steve, as to the frequency with which a transformation group will report? And I take from what you just said that the reports will come back to the board.
I think we can be a bit flexible with that, Paul. I mean, I think that the idea of it is to make it quite light touch, quite rapid in its assessment. I expect it will be setting up certain subgroups to take forward particular issues, so around our level of connectedness, for example, or some of the sort of volunteering and supply chain issues that we've seen. I can see us setting up groups which will probably meet quite regularly. My overall intention is that the group will bring back to board things to be considered in either its immediate response or in its planning requirements for the future that we can then use for our 3-year plan, our annual plan, and indeed changes and enhancements to our strategy. So I think it'll meet as often as it needs to, given where the agenda is going. I think we can keep that quite flexible. As a starting point, we'll probably meet monthly, but I think it's about keeping that under review. So it needs to be quite energetic, and I don't want it to become sort of just another set piece of like a committee. Forgive me on committees, they're very important, but you know it needs to be slightly different from that.
I think I accept that, Steve. I think it's important that we maintain the momentum that may have been created from what you outlined in your opening.
If I can add to that, the role of the board really is, as we know, is to set the strategy and ensure the delivery of that strategy. And that's the main focus of the board, as well as the governance and safety. And I envision, and obviously there's a lot to discuss, that the board almost becomes like the goal command and decides on the what. And then the delivery is in the organisation, and we get assurance on that delivery at board level. But it's to be discussed. But I think it's a mechanism in which we can take forward of the delivery of our strategy quicker than perhaps we have done in the past. Judith, Mansell, and then John.
Thank you. Thank you, Chair. First of all, I thought it was a really good document, I have to say, and I think congratulations to all those who've participated in writing it. It was very easy to read, and I think it really does set out the stall as to where we want to go. My two specific queries. One, I think probably would be for Andrew, which is around children's services. I did think it was a little bit light on some of the detail in there. Not seeing the links between community paediatrics and neurodevelopmental services. And I suppose on that stage, we did, before all of this, talk about having a paper to the board about children's services more generally. And that came from discussions at a regional partnership board. So I'd like to ask if that could be reconsidered at a stage in the future. And then my second question, which would be for Jill, on the paper on primary care, there's reference to Attend Anywhere, and the fact that a practice has declined to use it. May not be appropriate to say what that is in the board, but I would maybe outside the meeting like to know why that is and you know, the reasons behind that. And maybe I could pick that up could be picked up in the meeting I'm going to next week with the clusters. So thank you.
Okay, thank you, Judith. If I may, just before I answer the question, I'd like to extend my thanks to all of the frontline teams and our operational staff for their commitment and dedication over the last 10 weeks as well. I think you've rightly highlighted, both Chair and Chief Executive, the creativity and innovation we've seen, which I think at times in the situation has been phenomenal. I would also like to thank the support of the public and our partners in terms of in the way they've worked with us. I think in extending my thanks to the staff as well, I would also like to thank my colleagues around the executive table and their teams as well, and the way that everybody's worked together so seamlessly to be able to deliver some of the change to services that would have been required in such a rapid space of time. And it shouldn't be underestimated the amount of hours that a number of corporate teams have put in to make it possible what the operational teams have been able to deliver. In terms of the specific question, Judith, I think yes, in terms of the paper on children's services, happy to revisit that. I have to say that since we spoke about that, obviously with everything that's happened, I've not really had the time to have the conversations with Ros and with Delith around what that might look like and how we shape that. So it is very much on my radar as something that we've committed to and we need to pull together. So I'll take away from that, from the meeting, a need to explore that conversation and come up with a timeline for when we might be able to bring something back that's sensible, that isn't rushed, but gives you the assurance that you're looking for. I know. In terms of children's services, obviously we've had to employ a lot of the similar principles we've applied to all of our acute services in terms of red and green pathways and triaging appropriately at the front door. We have had to suspend some routine outpatient clinics, but all referrals are being vetted daily, and the teams are providing telephone review for urgent and long-term condition paediatric patients, as well as face-to-face reviews with those where it's clinically appropriate. There was obviously some changes we made right at the outset to paediatric services, particularly in Withybush and patient flows around the paediatric, around PACU there, to facilitate the red and green pathways for adult services and the broader front door for unscheduled care to enable us to have that red and green stream. And we're continuing to work with the teams on that and implementing that. In terms of neurological conditions, there are elements of assessments that can be undertaken, and that will decrease some of the impact on some of the waiting lists as far as we can. But all referrals are continuing to be screened, and in cognizance of the risks around that, patients are being reviewed and seen still. So that's notwithstanding some of the underlying challenges we've had with those services, the neurodevelopmental services, for example, in terms of staffing anyway, that have minimised our ability to have minimised our capacity or mitigated our capacity. And also, obviously, like all services, we've seen impacts from some of the shielding arrangements we've had to put in place and some of the risk assessments we've had to undertake as part of our COVID response.
Yes, thank you. And I will refrain from providing the name of the practice. I can let you know that later, Judith. But actually, it's a positive outcome anyway. And I think the important thing around what we've seen in terms of COVID is the vast way in which both primary care and also the public have changed the way in which they communicate with their services. And we've seen that phenomenal rise in terms of e-consultation, video consultation, things that we have been planning for years and probably would have taken us years to get to, were rolled out very quickly. And none of those systems are mandated. We've brought in eConsult, and I can send around a 7-minute brief to board members that's very helpful in terms of looking at the phenomenal rise in consultations by email from patients over a month's period. With Video Consult, Attend Anywhere was the free system that Welsh Government rolled out, and it was being rolled out in a phased way, and we were somewhere in the middle of the pack, I think, around that. But a number of other practices, including the one that declined Attend Anywhere, had already purchased their own system called Accurix. So we've got a number of practices that use Accurix as opposed to Attend Anywhere. So that was actually the reason in this case. So I think all of our practices are using some form of video consultation, be it Attend Anywhere or Accurix. And I think the point we made earlier around the Deaf Society, again, a lot of consideration has been made in terms of thinking about how vulnerable groups or people with different needs can still communicate effectively with their services at this time to make sure that they're not compromised really in terms of accessing care. But in this particular situation, Judith, it was simply the reason that the practice concerned had Accurix in place already as opposed to Attend Anywhere.
Thank you. Thanks for the comments about the services, both in primary care and the children's ones. Thank you.
Just briefly on children's services, apologies, this happened after the report. We also agreed at Gold. I know there's been concern in Pembrokeshire around the Withybush change for PACU, which had allowed us to keep 2 separate front doors at Withybush. Gold did agree that we would put a clause in that must be reviewed by the latest by the 31st of March 2021, if we can't do it before then, just so there's some reassurance that it is a temporary measure that we put in place.
Mansell.
Thank you, Chair. First of all, I want to echo Sam's words in relation to the excellent work that's been carried out by staff across the Health Board. And also thank you for your fortnightly, which has kept the CHC fully up to date. I myself have had 2 conversations with patients in relation to what Steve has mentioned about the increase in unscheduled care, one in Withybush, one in Prince Philip, and both were extremely positive on how things have been organised in relation to red and green areas. So thank you for that. Two areas I just want to make a comment on in relation to the report. There's been a lot of urgent service change carried out, which we fully understand based on this pandemic. But going forward, we need to ensure that if these are carried forward in relation to having a service change carried on, then I think this will need some engagement, definitely, and also in some areas consultation. So I just wanted to bring that up. I know that we haven't got a service planning meetings at the moment, but once this is over, we need to carry on as normal as we can. And the other one was that there's a 9 to 5 helpline for concerned cancer patients. I'd be grateful if that number could be shared with us, those calls you've received, as we've had some concerns in via our own survey as well. Thank you.
Thank you, Mansell.
Just on the second point, yes, of course, Mansell. On the first point around the service change issues, now that it's clearer that we're in a quarterly planning beat, and following our discussion actually on our last telephone update, I've asked Andrew, Jill and Karen in her role to be linking to your service planning meeting, so that there's a conversation as we're developing those plans with you about the sort of things that we are considering, so that you've got the maximum heads up given the speed with which we're working, and we can have a conversation about any issues as quickly as possible. So I'm confident we can make that work better now that we're in a a more, I won't say longer term planning, because quarterly planning is the shortest term we've ever had to do as a health board, but certainly feels a bit more able to give some consideration to that with some weeks in advance, hopefully.
Thank you.
Thank you. Jill?
Could I come back in response also to the CHC, please? Because one of the things that I think would be very helpful from the CHC would be working with us to encourage patients to access services as and when we now bring them back into the system. And we will be seeing some of those changes, as we've said, coming back in over Q2 and Q3. But you were mentioning cancer services there, Mansell, and we know that between March and April last year, in comparison with this year, we've seen a 58% reduction in referrals from primary care into secondary care, reflecting the reduction in patients actually coming forward. So those urgent services have always been in place throughout this period, but we know that there is a reticence of the public in terms of coming forward. And as we begin to step back some of our general primary care services, we're working with Welsh Government in terms of how those move back into place. We would welcome the CHC support as we send out some of those positive messages, and we've been doing that with our communications team around coming back into the services, seeking help when they need it, and we can assure them that we still have, as you've already said, those right services in place to protect the sort of red and green areas.
Yeah, thank you, Jill. Yeah, we've actually been doing that as we've been going along. We have had some concerns from patients, but I think it's just a case of understanding. It would be useful, I think, to have some sort of database in relation to what you were saying about how to contact the GPs, etc.
I was just going to support what Jill said, but also Mansell, it would be good to have a conversation, because I think one of the things we're finding as we're having the conversation with operational teams about how we bring services back online is just the level of complexity there is and challenge there is going to be in doing that. And so your help in terms of your role with the public in helping us manage expectations about what we can do and what we can do in certain time frames will be really valuable to us, because it's important we do it in a considered and measured way in order to ensure the safety of everyone accessing those services.
I think the details of those conversations could take place in the meeting that you're going to have, and then agree a joint way forward. So that's wonderful, thank you. Next is John.
Thank you very much, Chair. Can I refer to page 42 to 46 of the document, which refers to cancer services? I'm sure the board would agree that an unfortunate consequential effect of COVID has been on our cancer patients, and it notes there the disruption to our cancer services, which is something that obviously we do not want to happen. My concern, I guess, is that our cancer patients are most vulnerable. I don't want to read that there are issues in terms of access to treatment, diagnostics, or any of the tertiary services. Now, I accept that the document does note the 5 or 8, I should say, action points from the new framework that's been published by the Welsh Government, and there are some points of action that we're looking to address. I guess my question is, what has been done to understand the impact of COVID on the delivery of cancer services, and particularly on the individuals, the risks associated with that, and where is this performance metric being monitored, and the timelines for introducing these actions so that we can gain assurance as a board?
Thank you, John. Andrew.
Yeah, thank you, John. I think I would want to echo, I think, from one of your concerns, I think one of our concerns throughout this process has been the unintended consequences of the COVID response on particular access to some services, and cancer has been one that's been at the forefront of our minds throughout. I think it's probably worth just noting that in terms of there's a couple of things just to note. One is that in terms of the number of patients we've treated during this period, we've treated around 60 to 70% of what we would have treated during this period normally. A significant driver of that difference has actually been that in a couple of high volume cancer areas like dermatology and urology, we've actually seen less referrals coming into the system, which has therefore driven a lower level of activity during the period. So actually our concern on that front is that people haven't been accessing, or patients haven't been accessing primary care services early enough and being referred into the system for us to treat them. There have been a couple of services, and it applies to urology and colorectal cancer, whereby the complexity of some of the surgery has given us a problem and a challenge in terms of being able to maintain treatment as we would have liked during this period. And part of the Q1 response is around, and the focus of that is reinstating all of that urgent cancer work back into our system in a safe way. I think the first colorectal cancer patient is due to be operated on again next week, I think is the first list. So that's a very live issue in terms of reinstating that work. But there has been an impact on our overall numbers of interventions and treatments in the context of just the referrals that have been coming into the system. So the conversation we've had about wanting to reinforce to the public that our services are there to access, and we're working really hard to make sure that the various points that you need to have contact with the system, that they're safe and it's safe to do so. We would just want to reinforce that message and ensure people do, if they've got symptoms, that they do seek of non-COVID issues as well, that they do seek medical help and access support from the NHS as early as they would have done previous to COVID being an issue. So we're also continuing to work closely with Swansea Bay on some of the tertiary pathway issues, and one of the actions we've been able to take over the last few weeks is that whilst Swansea Bay were obviously impacted far more significantly from a critical care perspective in terms of COVID demand, which limited and reduced their capacity to operate for a period. We've actually had some of their tertiary cancer surgeons, particularly gynecology, which has been a problem for us, as you know, from previous board reports in terms of access, their surgeons coming to our site in Grangewilly to provide that surgery for Hywel Dda residents. So we have been working with the tertiary centre to try and maintain access, and there's further conversations going on both with Swansea Bay and with the Wales Cancer Network on how, on a regional basis, we explore that further to make sure we maintain those services. I think I would want to emphasise that the complexity of the pathways we need to have in place to bring people back just generally does mean that in terms of some of our capacity electively to be able to get through, to be able to safely bring patients through services, whether it's diagnostics or theatre, effectively our capacity on some lists and clinics is going to be about 50% of what it normally would be, just because of all of the PPE and cleaning and disinfecting protocol that needs to be in place to enable to keep everyone safe. And I should also point out that we've obviously got a detailed conversation, I think, at Queesiac in the next couple of weeks on the cancer position and the patient experience and safety impacts as well.
I know Phil would like to come in on this point as well, and also Steve.
So to check.
So Phil?
Oh, yeah. Yeah, as Andrew said, there is a large amount of activity being undertaken, has been undertaken through the pandemic period to date, including urology, ENT, gynecology, and breast cancer surgery, which I think is a tribute to the way we've all, the teams have organised themselves. And I think the dip in the cases coming through, as Andrew said, will be in part due to the services that we're able to run, and another part will of course be due to the way the public chooses to access services. Just thinking about John's specific question about how are we going to assess the impact, where will it be reported, the assurance on that, because inevitably when the screening programmes, for example, from Public Health Wales, many of them which are around cancer surveillance, they're there for a reason, of course. So if they're not taking place, there is inevitably going to be an impact. The issue with assessing that real time is that what we would like to assess, and we asked through our gold meeting, was to make an assessment of how many actual cases of cancer are we seeing, how many are we diagnosing, for example, how many are assessing, and then how many are being treated. The issue is that there's a period of time between when somebody's referred to when they're diagnosed and then treated. So at this moment, because it's only been a couple of months, it's quite difficult in each cancer site to make that assessment. However, in cancer services, actually, that assessment in time, not too much further down the line, it will be possible to make that assessment sort of numerically, we believe. And that would be assessed with the cancer services team, and I would expect that to be reported. I mean, it's reported anyway through our normal mechanisms, but given the effect on this, I think it could be reported easily through Quality and Safety Experience Assurance Committee.
The medical director's kind of made my point, but just to reinforce that, if I may, just for a second, there is I think board members have seen a more detailed cancer paper about the response to this. I wonder whether we should take that through QSIAP for a more detailed discussion, but also then think about the sort of issues that the medical director's raised around how we can continue to monitor the impact of this. The only other thing I wanted to say, cancer has been very much at the top of our list. It's not the only thing that we worry about, but it is a significant one. And for all those patients who've been delayed for major surgery, for the reasons that Andrew said, because the risk-benefit equation changed while we were dealing with a potential spike in COVID patients, all of those patients have been assessed by their clinician on a case-by-case basis based on their individual risk. And of course, those risks change the longer that we delay surgery, which is why we're now getting back into particularly the major colorectal work. So I think the teams, again, have done a very careful, clinically led process for this, and we're going to need to keep it under review. And I think it could be a substantive focus for the Quality and Safety Committee for sure.
Thank you. John?
Chair, may I come back, please? I think my question has only been answered in part, and I'm still questioning where the 8 actions within this plan and the activities that are being proposed here, where will those be monitored and what will be the timelines for these actions? And my last point is, we're unable to access the escalation plan that's attached to this section, and I would like to see a copy of it, please.
Sorry, John, I didn't answer that. I should have done it. It was on when I made a note to answer it. But it's being monitored. The action plan itself and delivery is being monitored through the Acute Bronze Group, which is still meeting twice weekly at the moment. And our intention was to have reinstated our cancer work by the end of June. So, well, by the end of Q1, which is by the end of June. So that's the timeline we're working to, and we're wanting to. The intention was to repatriate all of that work back to where it was on our 4 acute sites prior to COVID, so the outbreak. So that's what we're working to, and I can make sure you get a copy of that escalation plan as well if you can't access it. Apologies for that.
Thank you.
Thank you. Thank you. And so we will have the conversation with Anna about how this is scrutinised within Quality and Safety. Della, do you want to comment on this point or a different point? Because I have a queue of people.
Sorry, this point and another point that I think Jill touched upon in regards to the cancer services surgery. I'm glad that we will be reviewing it in QSIAP. My concern is some patients in Ceredigion and Pembrokeshire, from what I've read, would have to travel to Glangwili. Now, bearing in mind these patients will be compromised anyway, what are the plans to reinstate cancer surgery in Bronglais, for example, when we consider patients from Powys and Betsy Cadwaladr? That's one question. The other question I have potentially is for Ros about childhood immunisations. I'm concerned that within certain areas of Hywel Dda, health visitors provide childhood immunisations, but in other areas, GP practices provide them. And I don't know if we've seen a shortfall or a downturn in childhood immunisations. And maybe that will be something that we can discuss, Andrew and Ros, when we meet.
Okay.
Thank you.
Do you want to pick up the surgery?
Yeah, I mean, I think, our overwhelming desire, Dennis, would be to providing our elective work for cancer and everything on all of the 4 sites as it was prior to COVID, and that's certainly what our ambition is to work back to. I think as I've outlined, I think some of the challenges we've got are quite significant and they're quite complex, and the teams, as Steve alluded to earlier, these plans are all clinically led with the clinical leads, and they're making some very considered and measured judgments at the moment about how to restart some of these services safely. So any pathways that are adjusted like that are purely about how do we mitigate the risk at the moment of people not having surgery, balancing it off against the risk of the ongoing potential for an infection. I think one of the things there's 2 things we're very concerned about. One is that we know, or the evidence is that if you contract, if you become COVID positive either at the point of surgery or during the course of your recovery, during the course of your stay, having immediately post-surgery, then your the mortality associated with that procedure is significantly increased. So there's a risk to that. And also, as I said, we know that in terms of some of the, so therefore the way we've had to design some areas and some departments and some of ITU facilities, it means that we're not necessarily able to have red and green patients everywhere for everything. And so we're just working through the implications of that, really.
Thank you. I've just had a note, I think it's passed by Paul, about we could have a detailed conversation about a lot of the services, but I think they're probably better had at committee level. And we can decide which committee, whether it's QASIAC or whether it's people, performance and delivery. And as we said at board, we wanted to keep the non-COVID services at board, which we have done, and it's really important. But I think if we could pick up also the immunisation question with Ross offline and in one of the committees, that would be really helpful. I'm going to bring in Owen, who's been waiting for a long time, and then Mandy, who's been waiting even longer. Owen.
Hello. Can you hear me?
Yeah. Yeah.
Oh good. My question really was about cancer services, so I think it's already been answered. But the one thing I did want to ask about in relation to that was the mention of the helpline in the report, and I just wondered about the level of usage of the helpline for concerned cancer patients.
We'll have to come back to you on that, Owen.
Because I suppose the point of that question is it's all very well setting up a helpline. It's whether or not it's actually used, isn't it, as to whether it's of help to the patients concerned.
Absolutely. Okay, that will be followed through. We put it in the table of actions. Mandy.
Thank you. Thank you.
It's a very brief point around PPE, and I just need to flag a decision that was made by Gold through the Gold structure around aerosol generating procedures and resuscitation. And the reason I need to flag that is because we took a long time to consider multiple and conflicting guidance that was issued to us through Public Health Wales, Welsh Government, and also the Research Council for the UK. And on the basis of consideration of that guidance, we took the decision to step outside and actually go for a higher level of personal protective equipment when undertaking resuscitation in primary care and some of our acute services. We also issued very clear guidance for our community services, mental health and learning disabilities as well. So that is different to what has been recommended through Welsh Government letters to us and through National NHS England, which has been adopted by Wales guidance. So I just need to bring it to the board's attention.
Thank you.
Just on that, we agreed in the covering paper that I'll go to QASIAC for assurance.
Thank you very much. And I think it's worth mentioning the quality review that you did as well, not just the quantity review, and the outcome being that the goggles weren't accepted to be as good as they should be, and they were withdrawn then.
And they've been withdrawn across Wales, and I've had confirmation this morning from the All Wales meeting that took place at 9 o'clock this morning. The concerns that we've been flagging for the past few weeks around the quality of the aprons have been picked up on an All Wales basis as well.
Good. And do we have a date when they might be withdrawn?
I haven't at the moment, but they're certainly looking to procure alternative supplies.
That's good to hear. Thank you. Simon? Simon there? Okay, we'll move on. Any other questions? Thank you. I think that's been a really, really good scrutiny of this report, and we will look in detail at the relevant committees. So thank you for that. And I'd just like to add to this that I'm really proud of this report, and it just summarises and brings it together, the incredible amount of work that's been done in very challenging times. So thank you both. Okay, so the next, thanks Steve. The next item on, actually, what time is it? It's 10:46. We will do okay, we'll have a 10-minute break. Seeing Mandy's non-verbal communication. Right, 10-minute break. If we can resume at 10:55 and we'll start straight away. Thanks everybody.